me to host this 40-minute discussion of complications of oropharyngeal and laryngeal surgery. I'm speaking to you here from Edinburgh in NHS Lothian. I'd hoped to be able to bring you a live video of complications of head and neck surgery, but unfortunately Andy Evans is away this week. So instead, I'm going to host this panel where we have some experts in avoiding and managing complications of surgery. Ashley Hay is one of my colleagues here in Edinburgh, Vin Paleri down in Marsden, and are we also joined by Faruque Riffat from Australia?
Yep, I'm online. Excellent.
Well, so I dipped in and out of it during a clinic this morning, and I see there's quite a lot of pictures and photos, but I was going to basically run through a few cases, as I'm sure everyone else has done, and maybe we have a discussion about the complications that you might encounter during oropharyngeal and laryngeal surgery, and how we might go about thinking about them, dealing with them, and discussing them with patients. So I suspect many of us are starting to dip our toe in the surgical management of oropharyngeal carcinomas. And but this is a procedure that many of us will be used to doing, but it can be associated with some significant short-term morbidity in the first instance. And I thought we might talk about hemorrhage, because it's a potentially life-threatening problem after oropharyngeal surgery. I wondered, maybe I could start with Ashley. Ashley, what do you tell your patients about the risk of hemorrhage?
Okay, so usually when we are discussing the risk associated with surgery, I think it's important to frame the discussion with the other sort of options and treatments that are available, so the patient understands the issues of radiotherapy and chemotherapy potentially, and then we go on to talk about what's involved with the surgery. Up in Edinburgh, we tend to do most of these cases as a sort of a transoral laser approach, and so we talk about the risks inherent with that, but then specifically with the bleeding, we explain that it is a potential risk, and that it can be life-threatening, but there are things that we do to try and mitigate that. And we usually do all of these with a corresponding Nectar section and ligate the arterial supply to that area to try and reduce the risk of that happening.
So tell us about that then. So what do you mean by that? You clip the external carotid artery, or the branches?
Yeah, so there's has been discussion about exactly what this means to ligate the artery, whether you just ligate the external carotid or you ligate the branches, or if you do both. My kind of understanding of the literature tends to be that if you can tie off all the sort of individual branches that supply the pharynx, and also the sort of the external carotid above the lingual trunk, that tends to reduce the chance of bleeding. But again, I think when we've looked at this to see exactly what people do, it is quite variable, and also depends on the anatomy, because there's a different branching pattern, different levels.
Well, maybe we could ask Faruque, what's your approach in your unit? What steps do you take to try and minimize blood loss?
So, Iain, we tend to do these by transoral robotic rather than laser. And so would certainly ligate. Look, I'm not sure if ligating the external carotid artery branches would reduce the hemorrhage rate. I think what it does is that it reduces the severity of the hemorrhage. When it does occur, it makes it easier to secure the airway for the anesthetist, and it certainly makes per-oral control in a take-back relatively safer and more manageable. I'm not sure if it actually reduces the rate per se. Most units report around 5 to
Faruque,
6%.
I can't hear you terribly well. Don't know if others can.
Hang on, one sec.
Might be a Marsden connection problem, Prof.
All right then.
Can you guys hear me?
Yeah.
That's much better, thanks.
Yeah, sorry. Now, Vin, what I was saying was that, look, we do these with the TORS approach, with the Da Vinci. We've done them with the Met Robotics. I don't think it matters what modality you use to treat the primary, because I think the hemorrhage rate with controlling the lingual and facial artery branches, which we would routinely clip, we don't tie off the main external carotid branch, because I think it does create back pressure. So the individual arteries are ligated, the facial and the lingual specifically, but I don't think that reduces the actual hemorrhage rate. I think it reduces the severity of the hemorrhage, and that's been my experience, that's been the experience with my colleagues, and certainly that's what's been published as well. We tell them it's about 5 to 6%. I think that's kind of in line with literature. That's also the audit of our unit as rates of secondary hemorrhage, requiring takebacks to the operating theatre for management. Now, what controlling the artery in the neck does is that it makes the securing of the airway much safer. It reduces the volume of blood loss. That's certainly the case, and it allows for per-oral control in the take-back phase. So what we do is both ligate the arterial branches on the neck side, but also when we do the TORS at the styloglossus. So I preserve the submandibular gland when I do these nectar sections. It serves as a very useful landmark when you do the TORS resection at the level of the styloglossus, and then the individual branches at the styloglossus, the lingual and the facial branches that feed into the tonsil, as well as the superior branch that comes in from the soft palatal surface, are all hemoclipped by the assistant at the mouth. So that allows for control of the bleeding, and I think that helps with the post-operative hemorrhage volume rather than the hemorrhage rate.
Okay, so you're clipping them close to the external carotid, and then again close to the tumor.
Correct. So when we resect the tumor, we clip it at the mouth end, and when we do the nectar section, it's done on the neck side as well.
Okay. How about yourself, Vin? Do you clip the main artery, the branches, or how do you approach it?
So if you move away from personal practice and look at the data dispassionately, there's two reviews on this. One is systematic review and a meta-analysis. The other one is a fairly large review, but some methodological issues. But they both seem to point one way. If you clip, there are two types of bleeds you can experience after these resections. One is a minor bleed, other one is a major bleed. And a major bleed typically is one where you have to go to theater with the patient or you have to transfuse blood. If you ligate the vessels, the data indicates that there is a significant reduction in the number of major bleeds. Your minor bleeds may remain the same, but from major bleed perspective, you drop down threefold, fourfold. So that, to my reading, is enough information for me to regularly clip those terminal branches. So in a tonsil resection, I would clip the facial and the ascending pharyngeal artery. In a tongue-based resection, I would clip the facial and the lingual branches, because usually the facial goes around that facial artery bulb. And for a supraglottic resection, clip away the superior thyroid artery, both inside and outside. And I've come around to the fact that if you don't clip it, that, to my mind, if the patient has a major bleed and has a major adverse outcome from it, and that's happened in this country and abroad, that, to my mind, is tantamount to clinical negligence, because it is a simple measure to do and it's easy to sort out, and you can abrogate a major bleed in a substantial number of patients.
Yeah, and I think that's the point here, isn't it? That you're in there anyway. Why on earth would you not do it now that we recognize the evidence? Because you're never going to stop people having minor secondary hemorrhages after tonsil surgery. But these major events can probably be minimized. Well, maybe I could ask you, I wanted to just explore a few different aspects of this. One of the things that experts say is that really if you've got medialization of your carotids, you shouldn't be doing a transoral resection. Do you think that's true? Do you think that's outdated, or is that something that you would consider a patient not a candidate if they had medialization of their carotid on preoperative imaging?
So I've been in a medialized carotid situation twice, both in the recurrent cancer setting, and I would cover them with a flap of some kind. We just do a transoral robotic free flap inset to cover them. And if you have a medialized carotid artery, there isn't an excuse for not covering it, shall we say. In a primary setting, I think the incidence is very, very rare. More than 200 resections. I haven't seen or come across a case where I had to abandon a primary resection because of a medialized carotid artery. So my experience is zero, but when I see it in the recurrent setting and those patients don't have an alternative option, I think you ought to cover them up with some kind of biological tissue.
I don't suppose if Vin has limited experience, does anyone else on the panel have any experience of that?
This often seems to come up on the preoperative imaging, and if you're looking at a case of whether you think it's suitable or not. And I guess in Edinburgh we've looked at these, and because we haven't done an awful lot, that these hadn't been the ones that we'd been wanted to do. I don't know if you have more an experience, Vin, of.
I think it's rare actually to see them. The ones we choose for surgery are T1, T2s with appropriate neck nodal disease, and it's rare to see them in the setting. And the only ones where a medialized carotid artery is contraindicated is for tonsil dissections. If you've got a medialized carotid artery is a tongue-based tumor, go ahead, do it. With supraglottic, go ahead, do it. It's contraindicated purely in a tonsil tumor where you have to do a lateral oropharyngectomy. And as I said, I haven't had to not do a primary resection because of a medialized. In fact, many times I'm getting worried. I get to the stage where the patient's on table, I'm thinking, oh my God, I haven't checked for a medialized carotid artery. And then you look at it, sure enough, it's not there. So on balance, it's like my radiology colleague wanting to report IAM MRI for tinnitus. He'll say that I can report all my scans as being normal and I'll get it right 99% of the time.
Yeah, that's a good pre-test probability.
It is, yeah.
Okay, so last thing I was thinking about when I was thinking about what to ask this assembled group of wise people is that when I do a neck dissection normally, I wouldn't cross-match a patient. And I wouldn't really think about their cannula at all, about how long to keep it in. But these people are at a low risk, but a risk of really significant bleeding that can be life-threatening. Does that change your approach to whether you cross-match or whether you keep a cannula in for a longer period of time post-operatively? Maybe I can ask you, Faruque.
No, for a selective level 1 to 4 neck dissection, I wouldn't, not routinely, unless there was any other reason. I mean, it might get done. I'm not sure if it gets done as part of our pre-admission protocol anyway. No, I don't think it gets cross-matched. They might get grouping, but I'm not sure if they get cross-matched. But I certainly wouldn't request it. Cross-matching in our system basically means that blood can no longer be used for any other patient. So it's a real waste if you're going to use it in a routine neck dissection. So I wouldn't.
Yeah, sure. Would anyone have a different opinion on that? I think we're moving away from using cross-matching so much these days, aren't we?
So I think that there's a rationale for this. Most patients who bleed, in my observation, are those who haven't resumed oral intake by day 7, day 8. And if you've tied those feeder vessels off, if they're on oral intake, we usually send them home by day 5, 6, if they've gone home by then. The recurrent cancer patients, given our catchment area not being nearby, we keep them in for a good 10 days. But the bleeders I've seen are consistently those who haven't resumed oral intake, whose pain is poorly controlled, and then they just come up with a bleed. So we have a fairly rapid oral intake policy. We control the pain, get them going quicker, and that seems to lead to a lower number of bleeds. But then in anybody's experience, the bleeds are small in number. That needs to be factored in, but that's a rough, fuzzy logic of taking cannula out and not leaving things in. You want them mobilized, you want them get going as soon as you can.
So obviously perfect timing. You lead me into maybe summarizing that section then to say that hemorrhage is a really serious problem for these patients, but you can probably minimize it by being careful in your preoperative assessment and by being meticulous in clipping the branches of the external carotid, maybe even the main trunk, as Ashley mentioned, and then trying to get your patients up and going quickly after surgery. So to follow on from that then, what do we do about pain management in this group? Do you have a protocol that you follow, Vin? You sounded like you probably do from what you said.
Yeah, we have a protocol for those. Unlike laser microsurgery, be aware that transoral robotic surgery, especially tongue-based and tonsil, is a painful operation. There's no way getting around that. And these patients need proper pain counseling. They will need pre-operative. So what we do is we put them on pre-operative gabapentin a day before, and then run the gabapentin until the pain's fairly well controlled. Post-op for a short while, they're on some kind of PCA, and we hit the pain hard and get them swallowing fairly sooner in the primary resections, be it tongue-based or tonsil. Unless it's a multi-site resection, you can get them eating fairly soon. Get a flexible endoscopic evaluation of swallow done on day 1 or day 2 when the nausea settles. And then if the swallows seem to be safe, get them going. And that's usually a good prelude to a good outcome. And the pain should be well controlled, a good pain chart, and that's key. So pre-operative gabapentin, carry on with that until the pain settles nicely, or when the patient's feeling too dizzy and too nauseous or sedated with that. NSAIDs and paracetamol is appropriate.
That sounds like a good approach. Has anybody any experience of different approaches there? No. So I mean, I think that sounds like very reasonable, because otherwise people are presumably using standard opioids, paracetamol, and really what they would do for tonsillectomy. But it's interesting to hear that you're going that extra length of giving pre-treatment gabapentin. Okay, well,
I've tried to follow your protocol before, Vin, for some of these cases. I've had trouble getting hold of the IV gabapentin. Is that what you tend to use? Is that, have you had a problem with that, or is it just our pharmacy finding it difficult to use?
I think it's oral, Ashley, if I'm not mistaken. I can send you a GEARS protocol that we set up at the Marsden in conjunction with the pain team. I'll send it to you. I'm fairly certain it's pre-op dose the day before the operation and then post-op through the NG tube. I could be wrong, but I have to give full credit to my clinical nurse specialist colleagues, my HP colleagues, and my pain team. So I rarely get involved in that, but I say I want the pain controlled so we get them swallowing sooner.
Okay, great, thank you.
Okay, well, why don't we move on? We've done about 15 or 16 minutes there on oropharynx. I don't think we cover everything, but maybe we can move on now to transoral surgery of the larynx. Let me get there. So I would think that most people would look at a case like this, which I took off Google rather than myself, and would think that this might be a good candidate for a transoral laser surgery. And this is a relatively straightforward procedure, and hopefully there's not a huge number of complications associated with it. Otherwise, we wouldn't be thinking of it. But maybe we could talk about laser fire. This is, we take a lot of steps to try and reduce this, don't we? With mat instrumentation, laser tubes, we dress the laryngoscope in wet swabs and all the rest of it. Now, personally, I've never seen one. Does anyone have experience of dealing with them? They sound like they're very dramatic.
I missed that, Iain, dealing with the laser.
With the laser fire.
I've had a fire with a robot once.
I had a
sorry, Iain, we've got, obviously prior to the robot as well, but even currently for the larynx, we've got quite a large number of patients, in excess of 250 now, that we've documented for transoral laser, and we've had 2 episodes of laser fire, one with the robot and one with TLM, and on both occasions they've undergone root cause analysis, and yeah, I mean, they are fairly I was present in one of them. The other one we sort of reviewed within the unit, so I'm aware of the facts of the case. But yeah, they're very spectacular when they do occur. The one with the laser, look, you know, I'm sure we all know this. You need to have 3 components. You need to have the fuel, you need to have the oxygen when you have the laser fire, and you need to have the igniting event. In the one that was involved in TLM, it involved combustion of a laser-safe tube. So it can certainly occur. Laser-safe doesn't mean it's not combustible. It just has higher heat resistance material. But in the wrong hands at the wrong time and the wrong sequence of events, they certainly can occur. But I think the management of these are pretty standardized. In our operating theaters, we have we have the laser fire steps on the wall of the operating theater. Every case, the nurses have saline and water drawn up to douse the airway if that's needed. Obviously, you remove the tube immediately, put the fire out, and secure the airway, usually with the tracheostomy, which is what we did, and perform a bronchoscope to keep them in ICU and reassess the airway again in 48 hours. There was no adverse sequelae for the patient, but yeah.
That's good. That was well managed, and I would think it's a frightening thing to happen on your...
It's like a blowtorch on the microscope.
Yeah, sure. Okay, well, that's obviously a very dramatic complication, but hopefully extremely rare. So maybe we could talk about some different aspects of this which aren't so dramatic. Most of our patients in Scotland would definitely choose a laser resection if we offer it over radiation because of the convenience, the one-stop nature of it. And in fact, we sometimes even try to offer this as the diagnostic resection. But I wonder, maybe ask you, what do you think about the difference in voice outcome? I know this isn't really proven, but what's the difference in voice outcome between laser and radiation treatment for early glottis?
Well, typically, you kind of taught that the low dose radiation is supposed to give you improved voice outcomes, but my kind of finding is it can be totally variable. I mean, I've seen patients that have radiation that have had poor voice outcomes and poor swallowing outcomes for early larynx, and I've seen people that have had excellent outcomes from radiation. You couldn't tell that they've had treatment, and then on the surgery side, you can do these sort of cases, and patients, again, you could never tell that they've really had much done, and then you can get the a web if you've gone slightly too anterior, and they get a lot of volume loss, and then they can have quite severe sort of effects on their voice. So I think it's very, very variable, and it's sort of case by case, really. I think maybe that's why some of the studies trying to compare these 2 treatment modalities have failed in the past, is because they're so different, and the different patients lend themselves better to different treatments.
Sure, and different priorities, I think, as well, don't they?
Yeah.
Patients. So you spoke about the anterior commissure, and there are definitely difficult parts of the glottis to get to, aren't there? Then do you do a lot of transoral laser surgery? Are there parts of the larynx that you would say are not suitable for transoral laser resections?
All parts of the larynx are suitable for laser. I don't use the laser anymore for supraglottic tumors. I just use the robot exclusively. But for glottic tumors, laser is still the tool of choice. To get back to your question, Iain, about the voice outcomes from laser versus radiation therapy, we know that Martin Birchall's trial didn't take off because patients saw the benefit of having a one-shot treatment versus so many days of radiation therapy. But let's park that aside for a minute. There's one smaller randomized control trial that Mark Taylor reported from Ontario a while back. And that is a nicely controlled group where there was no difference in voice outcome for patients with T1A, T1B disease. That includes the anterior commissure as well, whether they had radiation therapy or laser surgery. And that was a longer term outcome as well from a voice perspective. So to my mind, I'm reasonably convinced, having read the literature and having done this for a while. And what's most important to me is the decision making behind this by high-end voice users. So I've so far treated 5 high-end voice users who came with early glottic cancer. We went through the entire decision-making process, seen by myself, seen by my radiation oncology colleague, and they came back and said, everybody chose laser surgery. And the reasoning was interesting. They said, for me, for my voice, what's most important is my ability to keep my larynx moist and keep the mucus flowing when I'm using my voice at whatever I'm doing. And these are singers and others in that profession. With radiation therapy, your 50 gray in 20 fractions, 1630, whatever it is, it covers the entire larynx. So the entire larynx is now dry. With laser surgery, you're performing precision surgery to take out just the lesion alone. And all of these 5 patients now have persevered with their high-end voice use. One of them said, oh, I'm using my voice differently now. I can sing songs I never sang before because I've gone up 2 octaves, but that's a different story. But they have persevered with their original profession. And that to me is quite significant. I tell that story to my patients simply because there is no evidence base for this. It's weak evidence base at best if you try a head-to-head comparison, but all the data seems to indicate one way. And finally, the NICE guidelines, when we did a health economic evaluation of this for T1A and T1B disease, across a number of cost effectiveness scenarios, the ICER, the incremental cost effectiveness ratio, favored transoral laser surgery for T1A tumors and T1B tumors. So to my mind, I think this should be the default option at any MDT across the world for T1A glottic tumors.
So maybe we turn to Faruque. Is this part of your standard practice as well? I'm guessing it is.
Yeah, I mean, Iain, I think I agree with Iain. I think for T1s, assuming patient factors allow good access to the larynx, I think that's quite important. It's not just what we're looking here are all the disease factors, but there are patient factors with their teeth, with their anatomy of the jaw, that must allow good exposure of the larynx. I think the key thing that we need to be confident of is that we've removed this lesion with some amount of margin. You could debate what that could be, but exposure to the larynx is vital. But I think I'll just add 2 things. One's both been our experience, and even if you look at Steiner's original papers, we are a referral center for a lot of these laryngeal cancers in our region. We drain about 2.5 million people, and 10% of our resections have no residual cancer. So these are patients who have been biopsied by our colleagues and have been sent to our MDT and undergo re-resections of their laser scar or of any visible macroscopic leukoplakia or disease. And nowadays we can use NBI to further enhance our diagnostic abilities. And yet, over time, and this hasn't changed, there's about a 7 to 10% rate of negative resections. Now, what that means is that if these patients choose the radiation arm, then 7 to 10% of normal larynxes are being radiated, who are obviously going to have a potentially better voice. And so you're not comparing apples with apples. I think that's the first thing. And the second thing, I think what's advanced in laryngology is certainly augmentation techniques. I think for a long time, we resected the cancer. We had a post-operative sulcus or a period of glottic insufficiency, a glottic gap. Patients were breathy for years. But nowadays, we're much more aggressive in post-op augmentation, in vocal rehabilitation, both with our speech and language pathologists, as well as various injection techniques over time that have become refined, allowing us to restore volume to the larynx. I think a lot of these patients get a period of supraglottal hyperfunction, which our speech pathologist can work with. And then we can do subtle augmentation, and especially with the strobe, you can really close the gap. And even big type 4 resections can get excellent augmentation outcomes. So I think you need to look at the voice holistically rather than the immediate week 6 voice.
That's great. Okay, well, I'm sure Jay wants us to keep pushing on here because we've a few others a few other subjects to cover. So let's move on. Now, this is something I personally don't have any experience of. It is the transoral approach to a supraglottic tumor. But I suspect the two non-Scots here probably do. My skepticism about this is presumably this patient we see here with a tumor in the artery-hypoglottic fold needs not only obviously an R0 resection, but bilateral Nectar sections. And I just wonder how the faculty feel about the morbidity of that in comparison to radiotherapy alone, admittedly to both necks and primary, but how do you think those two compare? Vin, do you have a comment on that? Is that something that you would take on, a case like this?
We would. I think we had to once again very carefully assess a patient for these supraglottic tumors, because in the short term, exclusively in the short term, the swallow impairment can be significant for supraglottic tumors, but in the long term, their swallow bounces right back to normal, if not near normal. So we'll have to assess them very carefully. The tricky margin will be the inferior margin. If this goes right into the ventricle and onto the cords, it's a different story entirely. If it's limited to the ventricle, then we'd sit down, have a discussion with the patient, offer them both treatments, and let the patient make the choice based on the information given to them and their own preferences. But I would tackle this transorally with a robot in my hands. And what you would do is split the epiglottis down the middle, see the lower aspect, and very systematically dissect and remove the tumor. Supraglottic tumors do need a bilateral neck dissection, and it's level 2, 3, 4 clearance. Please make it a point to do 2 separate incisions as opposed to 1 incision. That leads to more lymphedema. I quite like 2 separate incisions, 2, 3, 4 clearance, straightforward. And we're talking about complications. From a recovery perspective, with appropriate speech and language support, if these patients had decent preoperative function, which I suspect this patient will, given an early supraglottic tumor, you would expect swallow to come back to where they are in 6 weeks or so in the setting. The worry is the closed margin, the positive margin. And those are the cases where you need to choose them very carefully. But over and above everything, the single reason for offering them upfront surgery is this. If these patients recur after radiation therapy, the sole option you have in the vast majority of instances is total laryngectomy. If these patients recur after surgery, you have further surgery in your armamentarium, which includes open surgery, which is open partial laryngectomy, or transoral laser or robotic surgery, or radiation therapy. So if you look at larger case series, there's no randomized control trial on this. There never might be, because we put one application in 5, 6 years ago to see how UK bounced back because we couldn't make the numbers match up. But large observational series indicate that in patients who are offered surgery, the bias notwithstanding, the laryngeal preservation rate is higher, and the difference is about 20%. In patients who are offered upfront radiation therapy, your sole option for recurrence is for them to have total laryngectomy.
Okay, well, listen, we have 7 minutes left, and I thought we shouldn't really leave morbidity and complications of surgery without talking about a total laryngectomy. And it's obviously a morbid procedure. It's done for advanced disease in the most cases, or salvage cases. And the most common short-term complication, I suppose, and can devastate an inpatient stay is pharyngocutaneous fistula. So I wonder how, if we're talking about primary laryngectomy, or perhaps, do you change your technique, Ashley, if you're in an attempt to avoid a fistula, depending whether you're doing a primary or a salvage case?
So usually if I was thinking about doing a salvage case, I've tended to err on the side of trying to do less of a neck dissection or omit a neck dissection rather than in a primary case. I think it's probably important to be, that's more important to adequately stage the patient. Also, if they've had chemotherapy, I would tend to be very willing to consider a flap coverage, and I have done for all of the cases I've done. And then the patients that have just had radiation alone and then require a salvage require a bit more of a discussion of whether a flap coverage over the top of your pharyngeal closure is needed. I guess then you also consider if you're having to do a pharyngectomy as well as a laryngectomy, if you're going to need some mucosal coverage, and then usually would go for a free flap.
Sure. Okay. Well, I suspect, I mean, obviously we work in the same unit, so I will give a similar answer. We have tended to use an augmented closure if it's in the salvage setting. How about yourself, Faruque? How do you try to minimize fistula rate? Is there anything you do intraoperatively?
Look, I mean, pretty much what Ashley said. In salvage cases, I definitely don't do neck dissections unless the PET scan shows nodal uptake. And most of them don't. They have focal laryngeal uptake. In a primary laryngectomy, I do neck dissections because accurate staging, and if they're N0s, they may well avoid adjuvant radiotherapy. I think meticulous closure of the neopharynx. I mean, I do a vertical closure. I know it creates a pseudoepiglottis. I think that causes minimal functional problems. And it's easy to teach the registrars and fellows. I have tried using a microscope. I'm not sure if it makes a difference, but you certainly see the closure line much better. And ENT surgeons are very adept at using the microscope. So I think we should use it. It doesn't increase the operative time, and it definitely get a complete view of your inversion sutures. I think one of the things I do, and again, I don't know if it makes a difference, is an on-table leak test. So once I close the first layer of the neopharynx, and that's the important thing to remember, it's really only the first layer that actually makes a difference. The rest of it is done for your security. I'm not sure if it makes it any more watertight. So I usually fill up a 50 ml syringe with diluted betadine, and one of my registrars goes to the mouth of the patient and inserts the syringe into the level of the pharynx and gently irrigates 50 mils of betadine. And if you put a clear white Raytec over your neopharynx, if there is a leak, you won't miss it. You'll definitely see the betadine coming out. And I think if there are little holes, it just means that you've got that chance then to close it. In salvage cases, and then the post-op care is pretty much the same. I'm sure we wouldn't do anything different to what any of you would do. In salvage cases, we would always use a flap. And I think in units which have microvascular expertise, which virtually all head and neck units in most parts of the world do, I think it's vital. And it's not about fistulas. I think it's now well known that flaps improve function. I think we need to think about management of these patients' dysphagia, which is much better with the flap. The diameter, the distension of the neopharynx is much more when you have an augmentation flap, and potentially better voice outcomes. So I think it's even thinking beyond the leak in those cases.
That's very useful. And you're talking presumably about augmenting the pharynx at the same time there, so they don't get left.
Correct. Yeah. So we do an augmentation free flap. I mean, in the last 8 years, I haven't seen a pedicle flap. Our reconstructive colleagues preferentially use a radial forearm or an ALT for these reconstructions.
Sure. Vin, maybe I could ask you, rather than we go over the same ground, do you ever use a salivary bypass tube? I hear some people are very keen on them. Toronto tell me they definitely work, but I can't see that in the literature.
There is a paper that, his name will come to me in a minute. He's a faculty in Toronto now, who put it out. But we use a bypass tube regularly for these resections where we put a free flap in. So the free flap is inlaid, and put the bypass tube in, put an NG through the bypass tube, and NG is stitched to the tube, bypass tube lower down, and then to the nose higher up. So when the time comes to take the bypass tube out in 6 weeks' time, all you have to do is pull on the NG and the posterior pharyngeal wall through the mouth, and the tube is delivered out. Fairly straightforward. And I think that leads to less dysphagia, and we've been doing that on a regular basis. But my takeaway points, the takeaway points for junior members of the audience from this are two, and I'd like to echo what Faruque said earlier. A meta-analysis with 900 plus patients, when your neck shows no disease in the salivate setting on a PET scan or an MRI scan, there is no point doing a neck dissection. That is just extra morbidity. There is no survival benefit whatsoever. Secondly, for salvage cases, do not ever think of getting away with the total laryngectomy alone. Just put something in terms of a new vascularized flap, because that reduces the fistula by 1/3, and the NNT for that is 6. So for every 6 patients you treat, you're benefiting, you're reducing the complication 1.
Okay, well, I think that's very useful. I'm aware we're pretty much on time at the moment, Jai. How are we doing from your perspective?
Yeah, I think maybe 1 more minute.
1 more minute. Okay, well, maybe I was going to finish talking about complications of voice rehabilitation. Does anyone have an opinion? I don't want to get stuck in COVID because, you know, that's not hopefully forever. Do most people feel that a primary puncture in the majority of patients who have total laryngectomy alone without pharyngectomy is indicated? Are there times that you wouldn't do that? How do you deal with that in Australia?
We do primary puncture, primary placement in primary total laryngectomy. So I use a Vega Provox kit. It's a 5-minute procedure using a Seldinger technique to put it in, and you need to do a long segment cricopharyngeal myotomy. I think that's vital. In salvage cases, they're placed as secondaries. I think that's just because you just want to avoid any additional morbidity if the patient does leak. But in primary, they're placed at the same time.
Yeah, I mean, we do very similar. Are you doing something similar in the Marsden, Vin?
Yes, any primary case with or without flap, partial pharyngectomy, put a valve in. But if it's salvage case, no valve at all, please, because you're putting the valve, most often the puncture goes through 1 centimeter below the lower end of your anastomosis of your flap to your esophagus. And if that bridge breaks down, you're looking at a fairly large leak, and you need it to happen to you just once to shy away from putting a puncture in. And it's happened to me once. You get a big old fistula there that just takes ages to settle. So if you can, and you lose nothing by waiting 3 months, it heals up nicely. 3 months later, with a TNO-scope, place the primary puncture exactly where you want it. And that's the beauty of performing a secondary puncture in the salvage population. You don't know how they scar up. You can put a valve in and they go in a funny fashion. But 3-4 months down the line, you do it under local anesthesia using a TNO-scope in outpatient or theater setting. Your speech therapist can advise you precisely where to place the valve based on the patient's preference, the angulation, and you get everything right the first time, as opposed to an awkwardly scarred and angled puncture site.
Great. Okay. Well, that used up the minute. So thank you to the panel. Thank you to Jay for having us. And if anyone listening wants to come and involve themselves in management of complications, then Edinburgh's a good place to come. Otherwise, we'll sign off and say thanks a lot for having us, Dr.
Thank you, Jay.
Thank you very much.
Thank you. Thanks, everyone.
Thank you, Iain. Well done.
Brilliant.
Thank you.
We'd like to invite Joanna Nixon from Edinburgh. You could start sharing your screen, please. You can unmute your mic as well. You can see your slides. Great.
Okay, good afternoon, everyone. Can you hear me?
Yep.
I'm Joanna McKay.